Good morning. My name is Nicolas Girard. I'm the head of thoracic oncology at Institut Curie. I'm chairing the Eurocan G8 thoracic cancer domain. And today we will discuss thymic tumors, the management of patients with advanced disease. These are my disclosures. The management of patients with thymic malignancies is a multidisciplinary management. And maybe before starting to discuss the management of patients with more advanced disease, I would like to stress some key findings about these cancers. The first point is that the incidence of thymic epithelial tumors has increased over the past 2 years, and this is because of COVID-19 pandemic, not related to the disease by itself, but more like to the CT scans that have been conducted in many people, leading to the incidental diagnosis of a thymic tumors. In France, we have a dedicated network for the management of patients, and then we are looking at the incidence of new cases, which has increased by almost 50% after COVID as compared to before the COVID pandemics. And hopefully, the incidence will decrease over the next year with all these early diagnoses of thymic malignancies. There are 3 points to consider before treating patients with advanced thymomas or thymic carcinomas. And the first point is histology. We have thymomas on the one side, thymic carcinomas on the other side, as discussed in another module of this educational program. Pathological review is recommended for patients, especially with advanced disease, where the diagnosis is usually done on a small biopsy, which may be challenging for the analysis of histological subtype. The other point is to consider staging, and I'm discussing advanced disease, but as you can see, these patients with stage 3 or 4 disease are highly heterogeneous. We have patients with stage 3 disease not amenable to surgical resection, especially the stage 3Bs, but again, it depends on the exact invasion of mediastinal structures. Similarly, patients with stage 4A disease may be amenable to surgical resection, especially in the setting of 1 or 2 pleural implants associated with the primary tumor. So, stage by itself does not mean unresectable disease, and the management of patients has always to start with the surgical question. There is some correlation between histology and stage. Thymic carcinomas, thymomas, B3 are more frequently diagnosed with advanced stage. We need a CTNM, a clinical TNM, because right now stage is not defined clinically, only pathologically after the surgical removal of the primary tumor. And there are many questions around staging. The 9th TNM staging is underway, and we will obviously have to integrate these changes, especially for the T descriptors, in our clinical practice. At the end, what is a key factor that actually defines 2 different patient populations? Well, this is the completion of surgical resection, which is far more relevant to predict the outcome of patients as compared to stage, to histology of the tumor. So, another point to consider is that we clearly need to have clear definition for what we are doing and how we are managing the patient. This is a series of key papers defining all the terms and a consensual management of patients, published in JTO more than 10 years ago, but still relevant for the reporting of the patients. We miss guidelines in the management of thymic malignancies. The evidence is actually limited. The grade of recommendation are limited because we do not have a single randomized phase 3 study. We mostly have prospective and retrospective studies. So the recommendations are mostly based on expert recommendation. This is why we have Huracan, among other networks, to discuss altogether the management of patients with complex disease. Advanced disease is part of this. The CPMS is our management system and platform to discuss these patients. We are organizing every 2 weeks, every month, virtual tumor board to discuss the management of complex patients. Other organizations have such an offer to discuss complex cases, ITMIG, but also the regional networks such as Time or Rhythmic. We have discussed in another module the management of patients with resectable disease, with surgery, possibly followed by radiation therapy. We know that this is a complex management. Defining resectability may be challenging. But today, for this module, I will focus on patients with advanced disease. And actually, this is, again, a heterogeneous group. In those patients, we have patients who may be amenable to surgical resection, but we need chemotherapy to reduce the tumor burden and make sure that we will have an R0 reduction. We have patients with metastatic disease not amenable to any kind of surgical or radiation therapy, any kind of focal treatment. And we have the patients with recurrences, which may be amenable to surgery or radiotherapy, but in the majority of cases will be treated using systemic therapies. So the first situation, that of primary chemotherapy, induction, preoperative chemotherapy. Well, this is a pretty straightforward management. We have limited levels of evidence, but in a real-world setting, the preferred choice is adriamycin and platinum combination. We may also use carboplatin paclitaxel or carboplatin etoposide. These patients with advanced disease but amenable to surgical resection have actually a biology associated with chemosensitivity, both in thymomas and thymic carcinomas, with high response rate, more than 70%. And actually, this is not only related to a lympholytic effect of chemotherapy that we may see in lymphocytic thymomas, because we have similarly a very high response rate on epithelial tumor cells, as highlighted by the high response observed in thymic carcinomas. This is a case of a patient with advanced disease, maybe not amenable to complete surgical resection, but patients had a biopsy. It was B3 thymoma. We did 3 cycles of CAP, and then the patient had a reduction in the size of the tumor, leading surgery, R0 resection to be conducted. So the key point is that preoperative chemotherapy in thymic tumors is not here to directly reduce micrometastases and increase overall survival of patients. Preoperative chemotherapy in thymic tumors is only here to reduce the tumor burden and make sure that we will have R0 reduction. In some patients, after induction chemotherapy, the tumor is still not amenable to surgery, and sequential radiotherapy may be done, possibly associated with chemotherapy. So if you use CAP as induction, maybe if you want to do then subsequent chemo-RT, you will have to use platinum and etoposide, which combines well with radiotherapy. So this is for primary chemotherapy, usually followed by surgery, or in some cases by chemoradiotherapy, possibly concurrent chemoradiotherapy. The second group of patients are those with metastatic disease, so mostly thymoma type B3, or thymic carcinoma at the time of diagnosis. And exclusive chemotherapy actually is based on similar chemotherapy regimens. We have phase 2 studies here. CAP is a preferred regimen, probably associated with higher response rates overall, especially in thymomas, as compared to other regimens. Carboplatin paclitaxel is an interesting option in elderly patients, patients with poor performance status, or patients with thymic carcinoma. When you have a patient not amenable to any kind of local therapy, this is actually suggesting aggressive disease. And we can see here that the response rate to to chemotherapy in the setting of exclusive chemotherapy are actually lower than those observed in locally advanced disease amenable to surgery. This is the 30-30-30 profile, 30% partial response, 30% stable disease, 30% disease progression. Interestingly, as I previously mentioned, anthracyclines are probably associated with higher response rate in thymomas, so this is my preferred option. This is less true in thymic carcinomas, and maybe my preferred choice for thymic carcinoma first line will be carboplatin and paclitaxel or carboplatin etoposide. Those patients with advanced disease, with metastatic disease upfront, have a high risk of developing disease progression or disease recurrence. And in this setting, we obviously may raise the question of local therapy, especially in the setting of a pleural implant. But in a majority of patients, we need to go for subsequent lines of systemic therapies. We have a list of chemotherapy regimen in the ESMO practice guidelines. We looked in the French network for these treatment strategies. So re-challenge with CAP is possible in patients who received less than 6 cycles, good cardiac function, and previous response to anthracyclines. Carboplatin paclitaxel is actually the preferred option in a second-line setting. You can also do carboplatin etoposide. And then for subsequent lines of treatment, switch to anti-angiogenic drug is possible with sunitinib. Other regimens may include pemetrexed, gemcitabine, capecitabine, or other agents. Especially in thymic carcinoma, second line mostly relies on anti-angiogenic agents. Each time a new line of treatment is initiated, an expected progression-free survival of 6 months or more is actually reported. So these patients are young patients, they have few comorbidities, so they may receive many lines of treatment. Anti-angiogenic agents are actually an alternative option to chemotherapy in the second, third line and beyond. Sunitinib has some activity, probably higher in thymic carcinoma as compared to thymomas. Still, we have many patients showing prolonged control of the disease with sunitinib. Another anti-angiogenic agent is lenvatinib, which was assessed exclusively in thymic carcinoma, and lenvatinib is then an off-label as sunitinib opportunity for patients with higher response rate in thymic carcinoma than sunitinib, nearly 40% response rate, and prolonged duration of efficacy. What are the new options? Can we go beyond these standard therapies, these standard of care in the management of patients with advanced thymic tumors? Well, first question is precision medicine, meaning the identification in a single patient of molecular alterations that may predict the efficacy of a targeted therapy. We have a minimal number of alterations in thymomas and thymic carcinomas, as seen on the Foundation Medicine database. Still, we have some patients who will show some KIT mutations. This is 10% of patients with thymic carcinoma. So I do recommend comprehensive genomic profiling of patients with refractory thymic malignancies, especially thymic carcinoma, to identify those alterations. And KIT inhibitors have historically been tested in thymic carcinoma and failed to show any kind of efficacy. As a reminder, KIT expression is a hallmark of primary thymic carcinoma, but not a predictor of efficacy. What predicts the efficacy of KIT inhibitors is the identification of a KIT activating mutation. Some of these mutations are similar to that observed in GIST or melanoma. Some are exclusively found in thymic carcinoma, and depending on the mutation, the location of the mutation on the KIT gene, the choice will be one KIT inhibitor or another. And here, if you have a mutation and you deliver a KIT inhibitor, including sunitinib, the response rate will be very high, more than 70%. The key point is that these drugs are usually multi-target drugs and will have also this anti-angiogenic effect that I previously described. A second targeted therapy is everolimus. We have a phase 2 study in thymomas and thymic carcinoma, mostly reporting on stable disease, but this is maybe a very interesting option, especially for thymic tumors, which are not really sensitive to chemotherapy, such as thymomas type A. I'm not sure that we need a biomarker, that the activation of mTOR-AKT is mandatory for the efficacy of everolimus. PI3K inhibitors, we have data with buparlizib, recently shown, but right now we have no data in patients selected based on the presence of PI3K alteration. It was not the case in this phase 2 study, so very hard to know if we select the patients based on the alteration, what will be the results. And finally, CDK inhibitors. Here is a phase 2 study with palbociclib. Again, non-selected population. These patients were not selected based on the CDK pathway alterations or the alteration of CDK in 2A. Still, even if we do not have this selection, we have a response rate of about 30% and prolonged duration of efficacy. I recommend comprehensive genomic profiling. This may be done through academic programs such as SPECTA, but it can also be done part of routine clinical practice. But at the end, we have KIT inhibitors for KIT mutations. We have everolimus, CDK inhibitor, and PI3K inhibitor without selection. I strongly believe that we need to select the patient for the use of these targeted therapies. Otherwise, there will be some disappointment. What about immunotherapy in patients with thymomas? Well, that's a very good, important question. At the end, we must consider that immunotherapy is contraindicated in thymomas because, as you know, thymoma leads to autoimmune disorders through the lower expression of self-related antigens, precluding autoreactive lymphocytes to be eliminated. At the end, when you give any kind of treatment, you may have some autoimmune disorders in thymomas. It was described with sunitinib, with everolimus. But if you do anti-PD-1, anti-PD-L1 agents, the risk is death of the patient, fatal myocarditis, rhabdomyolysis. This is frequently described. This has been published extensively, so this has to stop now. And thymoma is clearly a contraindication for immune checkpoint inhibitors. Still, we were able to conduct some phase 2 studies in thymic carcinomas, which are less frequently associated with autoimmune disorders. We have 2 trials with Pembro, 2 trials with Nivo, and these data show similar response rate, about 20-25% of patients with these responses and prolonged responses over time, but a significant risk of toxicity that may include rhabdomyolysis, that may include Guillain-Barré syndrome, that may include polymyositis, exacerbation of myasthenia. It may be hepatitis and transaminitis. So close monitoring of the patient, accurate selection, biological and clinical selection of the patients, accurate monitoring, clinical and biological. If you choose to do, this is again off-label, immune checkpoint inhibitors for patients with thymic carcinomas, I believe we cannot expand this possibility of label to patients with thymomas. There are still ongoing trials in thymic carcinomas and in thymoma type B3 with immune checkpoint inhibitors, either as single agent or combined with chemo or anti-angiogenic agents. So to me, this may represent an opportunity for patients with thymic carcinomas, enrollment in clinical trials from second line or in a clinical practice setting, more like in a third-line setting after previous exposure to chemotherapy and anti-angiogenic agents. But again, this has to be discussed. I would like to thank you for your attention and for following this webinar. We have an annual meeting of the ITMIG, International Thymic Malignancy Interest Group. In 2023, it will be in New York. It's a very important meeting. It creates a momentum. We have many data. All the experts in the field will be here. So hopefully you will be able to join. Management of thymic tumors is a multidisciplinary management. So you need a team, surgeons, radiologists, pathologists, thoracic oncologists, medical oncologists, neurologists. Everyone has to be here to discuss the management of patients. With that, I will stop here, and I thank you for your kind attention.